started to think about how we could work better with primary care, we quite often get people coming into our service that are seeking support because they feel that they've developed a dependency on a medication that where prescribing might have been initiated in primary care or in a hospital, and they'd remained on that medication for some time, but either the individual was concerned or had become concerned about continuing to take that medication, or the GP had become concerned about continuing to prescribe it. And there was definitely a bit of a struggle, I think, between primary care and drug and alcohol services around who was the best person to support that person in managing a reduction, if indeed that was what that person wanted. That's how we started the work in Fleetwood. We started to have those conversations, we started to look at the data. I spoke to our commissioners because it's not something we've specifically commissioned for, and our commissioners were absolutely in agreement. Yes, we know it's the right thing to do. Let's keep exploring it.
My role as part of the project was to really try and fill the gap in support with patients who may have problems with opiates, particularly prescribed opiates, patients who might be on a very high dose prescribed, or might be taking high dose or even lower dose opiates, but then maybe buying some opiates on top. Obviously, we're aware now with all the data that's coming out that opiates high dose long term is a really poor choice for chronic pain management, and working with patients to slowly reduce their opiate prescribing to bring it into more safer limits. Book at least half an hour consultation with that patient, really build that rapport, really explain to them as to why you're doing this. It's not a simple case of we're just going to reduce your medication and that's it, because again, that will just make that patient fear you more and cause that relationship to break down. You've got to give patients the time. If they trust you, you will ultimately always get a lot more out of the process.
Using the project, we could stabilise these people on a script, so they weren't taking things like illicitly or over the counter. They were just staying on the script, and we would work together to titrate them down, to bring them off the script, and I would do the psychosocial intervention to help them with maybe the mental health or any worries about withdrawals that they may have been going through at that time. So Jonathan would speak to the client, give them my information. He would then get consent off them for me to ring them and have conversations about initially coming in and speaking to myself about what it is that they want, what it is that they need, and why it is that they're doing it. Because they can't always talk to the pharmacists and the doctors about it because they don't want to, because they might be embarrassed, they might feel guilty, they might feel ashamed, they might just think that they're not going to get listened to. And not all my clients came to the building. I did a lot of work at the Wellbeing Centre, so we tried to keep it more GP based, so that people wouldn't feel nervous coming into a building for drug and alcohol service.
So I was invited into the MAPS project to look at learnings from setting POMs up, and how language is important, how we get patients engaged, where I found that a lot of GPs and pharmacists were struggling to get people engaged, and when they mentioned the word de-prescribing, a lot of people wouldn't engage because of that fear of just taking the medication off people. And it's more than that. It's more than what the word suggests. It's about looking at what else is going on in someone's life. It's about putting that person-centred and wrap-around care and support in place for this person. It has to be person-centred. You need to get to know the person that you're trying to reduce medication off. And it's not always about getting them off everything. It's about planting that seed. So even if they're not ready at that particular moment, it's about giving the information for them to read through it, to take away, and knowing that that support is there when and if they're ready to receive it. The only guidance you really need is sat in front of you and be led by that patient.
Me and Jonathan did what we call like an MDT, which is we'd both get together every Wednesday for half an hour. We'd discuss clients with consent, and we would talk about what we would like to do going forward. So we decided that every time that there was a DNA list, which means did not attend Jonathan's service, to reduce the medication, he would send that over to me, and then I would ring them to see if there was any anxiety about reducing the medication, if there was anything that I could do to support them in that, and I would then explain my role in greater detail. So by doing that, we then got more clients for our part of the project, and then Jonathan then got some of the people that had not attended his appointments coming back, because then they had both of us supporting them with that. Each time we felt like something wasn't working in the pathway, we'd look at it to make sure that it was safe to do first and it would benefit the clients and the patients, and then we would slightly change it. So I would always say, especially with this project, we was always learning, because we was like a primary care and a drug and alcohol organisation coming together who work quite differently. So together we just learned every week off each other through the MDT, through the pathway.
I'm really positive about what's being produced, because I think what it demonstrates and shows is that a clinical pharmacist, along with the support from an Inspire, Rebecca at Inspire, and that biopsychosocial support she gave the patient, is really supportive. So dose tapering in quite complex patients can be done safely, and they are supported from an individual who is trained in the biopsychosocial model. So I think that's, really, really exciting. Partnership building is definitely the way to go forward. And what the evidence shows is that those that live in a high area of deprivation, the more likelihood they are to suffer pain and therefore be prescribed an opioid. So it's vitally important that we look at the biopsychosocial model of care, and actually drug and alcohol teams and the work that Inspire does in Fleetwood is really positive.
If we can work together to reduce your opiates really slowly, really gently over a course of a few months, at that person's pace, if we do it really gently, it's possible that the pain won't actually change. There might be a small increase in pain just after a dose reduction, but this usually balances out after a couple of weeks. And then when you see them at the follow-up appointment in a month's time, they'll quite often say to you, "Do you know what, Jonathan? I'm in no more pain now. I'm actually a little bit more alert. I can actually do a little bit more. I've got more energy. I'm able to play, see the grandkids more and things like that." And again, it's building that holistic care and try and see what that patient's goals of treatment are.
So my ultimate goal is to sort of get them back looking at life again as life, and not just being sat at home, not really doing much, and just living day to day.
No matter what size practice you work in, all the clinicians that are prescribing need to be aware of the project and actually support it. And for not only for the pathway to be implemented, but certainly look at how they're currently prescribing opioids, and to make sure that when an opioid is prescribed, it is reviewed appropriately, and have systems and pathways within the practice to ensure that's done appropriately. And over time, what will happen is, hopefully, all the complex patients that are on quite high doses, or those that are on multiple opioids, or those that are on opioids with medication that can increase the risks, such as the gabapentinoids and benzodiazepines, over time that risk will reduce, and hopefully you will reduce your risks of others because you're prescribing more judiciously.
We need to put support in place across the whole of the UK. There's hundreds of thousands of people out there struggling, and we're not doing nowhere near enough. This support needs to be put in place, and it's not one service or another service. It's about all services coming together for the sake of the patient.
I think even though we work differently, we can always work collaboratively, and that's been shown on this project, how we can work collaboratively with primary care networks, with the GPs, with the pharmacists.
If a practice or primary care network was thinking about implementing this They would need engagement from obviously the stakeholders, and to work with the ICB, with the local authority and with the drug and alcohol team to see whether something similar could be set up.
I'd like to see the learning from this shared with other areas so that people can take a look at what we did and perhaps find some inspiration in that and maybe some parts of it that would work in their area that they'd want to replicate. There's clearly, there's clearly a need. We've done probably a small scale, initiative within Fleetwood, but the impact's been big.